Hello everyone, I'm Dr. Ragavi, one of the mentors from the StudyMEDIC team. We are glad to bring you the Kickstart series, which is going to deal with a specific topic in each module, and once you listen to these videos, you will be masters of that topic. So today we are going to look into bladder pain syndrome. I know all of us would have read Harry Potter, and I believe anything is possible if you have got enough nerve. Get out of your comfort zone and get things done. Before we go into bladder pain syndrome, here is an outline of the topics in urogynecology, and this includes overactive bladder syndrome, bladder pain syndrome, prolapse of pelvic organs, stress urinary incontinence, and urodynamic charts. Here are a few tips and tricks for you to deal with questions from these topics. Remember, there will be clue words in each question which will lead you straight to the answer. For example, in a woman presenting with urgency and frequency, that is overactive bladder symptoms, if there are words like frail or old, that means you should not choose oxybutynin but instead should go for something like mirabegron. Revise the urodynamic charts. I believe we have a Kickstart video on this topic. Revise the video and don't just rely on theory. For each of these conditions, there is a specific algorithm, a step-by-step approach, and your questions will mostly be asking you what is the next step or what is the most appropriate treatment. So as long as you go by the algorithm, you can never go wrong. Let's start today's topic, painful bladder syndrome. It is defined by the International Continence Society as suprapubic pain related to bladder filling. That is, the patient will feel better after emptying her bladder or voiding, which is a distinctive feature of bladder pain syndrome. As in urinary tract infections, the patient will have pain even after voiding. And this pain should be accompanied by other symptoms such as increased daytime and nighttime frequency in the absence of any identifiable pathology or infection. The ICS reserved the diagnosis of interstitial cystitis to those patients with the typical cystoscopic and histologic features. So what are these features? So this classification is given in the grain top guideline by RCOG, which classifies bladder pain syndrome according to cystoscopy and biopsy findings. So any patient who hasn't had a cystoscopy and a bladder biopsy is classified as XX, and based on the cystoscopic findings, if cystoscopy is normal, then it is mentioned as 1. Presence of glomerulations, like glomerulations are areas of submucosal bleeding. When they are present, then they become cystoscopy grade 2, and presence of typical Hannus lesions makes them grade 3. When these lesions are biopsied, if they are normal, then it is grade A. If they are inconclusive, it is grade B. Or if the biopsy shows distinctive inflammatory infiltrates, presence of mast cells in the detrusor, and granulation tissue, and or intrafascicular fibrosis, then it becomes grade C. So a patient who is said to be 3C means he has classic Hannus lesions with typical histologic features on biopsy. That is, this is the most advanced stage of the disease. So the approach in a bladder pain syndrome patient is, in any patient with chronic pelvic pain, pressure or discomfort perceived to be related to the bladder, accompanied by at least one other urinary symptom such as persistent urge to void or frequency, do a medical history, a physical examination, a routine urine analysis, urine cultures if required, or a prostate-specific antigen in males of more than 40 years, uroflowmetry, post-residual urine volume, and a cystoscopy and biopsy as required. So, based on this, you will be able to treat the condition. So, what are Hannus ulcers? This is a typical cystoscopic image of a Hannus ulcer, which shows a center area which might be white or scarred with blood vessels radiating from the central area. These are other pictures of Hannus ulcers. The first 6 pictures show a central red spot with radiating blood vessels surrounding it, while the remaining 6 pictures we're going to show you areas of white fibrosis in the center with radiating blood vessels from it. Both of these are pictures of Hunner's ulcers only. You might be getting cystoscopic images like this, and you might be asked to identify what these represent. These are again Hunner's ulcers with a waterfall effect. Like hydrodistension, that is, when we are filling the bladder to the maximal bladder capacity at a pressure of about 60 to 80 cm of water for a period of less than 10 minutes, it is called as hydrodistension. It is believed to be one of the therapeutic modalities for treatment of bladder pain syndrome, in that during distension of the bladder at its maximum systometric capacity, there is ischemia and the neurons, end neurons, are appeared to be destroyed, thereby correcting the neurological pathway of pain and giving relief from bladder pain syndrome. So, during this hydrodistension, this typical appearance of waterfall effect can be noted, wherein the Hunner's lesion keeps on bleeding and forms such a coagulum at the center. These are cystoscopic images of growth in the bladder suspicious of carcinoma, so that you can differentiate between these and the classic Hunner's lesions that I have shown in the previous slide. So, how do we manage this condition? The management of bladder pain syndrome happens in step-by-step approach. So, as we already saw, do an initial assessment, assess the urinary symptoms, pain and quality of life, do a urine dipstick, and if positive or necessary, do a midstream urine culture. Do a free physical examination, frequency volume charts if required. If there is urinary tract infection, treat and reassess. Other causes like malignancy, infection, overactive bladder, presence of calculi in the bladder, urethral diverticulum, bladder outlet obstruction, prolapse of pelvic organs, endometriosis, radiation or drug-related cystitis like cyclophosphamide should also be considered. So once you have made a diagnosis of BPS in a patient with all the symptoms without any of these other conditions lasting for at least 6 weeks, then the first line therapy is going to be conservative. Analgesia, stress relief, dietary modification, that is avoidance of certain foods which worsen the symptoms, for example citrus fruits, spicy foods, tomatoes, etc. Exercise like pelvic floor relaxation therapy, physical therapy in terms of acupuncture can help. Usually, we ask the patient to keep a food diary as well as a bladder diary to identify the triggering factors and to assess the urinary symptoms. If these first line treatments fail, then the next step is going to be refer them to secondary care. Only in secondary care do we start oral amitriptyline or cimetidine. If this treatment fails, then refer to a multidisciplinary team, a pain team and or a clinical psychologist. So the third line treatment is going to be intravesical instillation of dimethyl sulfoxide, heparin, botulinum toxin A, lignocaine or lidocaine, chondroitin sulfate and hyaluronic acid. All of these are helpful in replenishing the gag layer, that is on the inner surface of the bladder, thereby reducing bladder sensitivity and improving the symptoms. If all of these do not work, the next step is going to be neuromodulation, which includes posterior tibial nerve stimulation or sacral nerve stimulation. SNS or sacral nerve stimulation is an emerging treatment which is believed to work in this case because by gateway control of pain, that is, when there is a non-noxious continuous stimuli through the sacral nerve implant, that is going to shut down the pain stimuli from being transmitted, and thereby symptoms in BPS do improve. The other option is oral cyclosporin A, an immunosuppressant, which is usually given at a dose of 2 mg per kg in 2 divided doses. But however, cyclosporin A is more helpful in patients with Hunner's ulcers. Also, these patients need to be under continuous monitoring with renal function test, liver function test and blood counts, because anyway this is an immunosuppressant. The fifth line therapy includes cystoscopy and hydrodistension as we saw earlier. and if presence of Hannah's lesions are there or if major surgery is considered, you have to refer to a tertiary care. So if you have Hannah's lesions, then you might consider fulguration of the lesions, installation of or excision of the lesion or installation of steroid into the lesion for treatment. And the last resort for management of bladder pain syndrome is going to be surgery, which is usually never recommended because these are going to be highly morbid procedures like partial cystectomy or urinary diversion procedures using a ileal conduit or bladder augmentation procedures. The treatments that RCOG does not recommend any longer are long-term antibiotics, intravesical BCG, resiniferotoxin, intravesical pentosan polysulfate, high-pressure long-duration hydrodistension, and long-term oral glucocorticoids. Initially, this PPS or pentosan polysulfate was recommended, but RCOG no longer recommends this because of two reasons. One, there has been incidence of macular retinopathy causing vision disturbances in patients on oral PPS, and intravesical installation of PPS may not give the exact expected results in studies, so RCOG does not recommend it any longer. So in pregnant women with BPS, the safest oral agent is going to be amitriptyline, and if you are planning for an intravesical installation, try heparin. Although one course of DMSO can be used prior to pregnancy for symptom remission with good pregnancy outcomes like delivery at term, normal birth weight and postnatal BPS symptom control, DMSO is known to be teratogenic in animal studies and hence is not recommended during pregnancy. So here we go into few EMQs based on whatever we discussed so far. So these are the options. For each of the following clinical scenarios, we are going to choose which is the right option to proceed with. Our first patient is a 30-year-old woman presenting to the gynecological outpatient department with a 6-month history of urinary urgency, frequency but no urge incontinence or nocturia. The GP letter states that urine analysis is negative. So in this patient, to know more about her urinary symptoms and quality of life and the reason for this urgency and frequency with sterile urine, the next step is going to be a bladder diary. A bladder diary is a diary which includes the following columns: the patient's input, that is intake, output or urinary output, which the patient measures with a jar, and what were the events, that the volume of urine that she has passed, and whatever events that were taking place when she had a leak, like whether she had a cough, whether she was laughing, whether she was playing something, and all that is usually mentioned. This helps us to understand the total amount of intake in a day, the distribution of this intake, like whether the patient has more fluids or coffee in the evening, which is going to worsen her overactive symptoms, and the amount of urine voided during each void. Also, what are the events which are worsening or relieving her urinary symptoms. In this case, as this patient does not have any urinary leakage, a dry OAB may be managed with a symptom diary for confirmation of diagnosis and patient feedback with lifestyle recommendations before commencing medications. Our next patient is a 72-year-old woman presenting to the general physician with presence of blood in her urine for the past 2 months. She has no fever or any other systemic symptoms. Routine analysis of urine shows a blood of 3+. The patient is otherwise well and has been brought to the GP reluctantly by her persuasive daughter. The patient apologizes for being such an encumbrance. So in this case, the red flag signs are presence of blood in the urine without any symptoms or signs of infection. That is, the patient has no fever, there are no pus cells in the urine, but there is still hematuria. This is more suggestive of a malignancy, and the next step in management would be referring the patient under 2-week rule. So, presence of blood in the urine with no suggestion of urinary infection is a worrying symptom that needs an immediate referral to the secondary care. Some units have a dedicated hematuria clinic for this purpose. Usually, in the secondary care, these patients might go for imaging of their bladder, kidneys and ureter, and if suspicious may require a cystoscopy and or a bladder biopsy if any suspicious lesions are noted. Our third patient is a 41-year-old woman presenting with a long history of probable recurrent urinary tract infections and has been treated with presumptive antibiotics when she lived abroad. She has severe pain in the bladder area and also urinary urgency, but there are no leaks reported. She also reports occasional hematuria that resolves spontaneously. Serial urine cultures have always been negative, including for fungus and atypical bacteria. So what is the next step in this patient? In this patient, the symptoms are suggestive of interstitial cystitis. A cystoscopy and a probable biopsy will help in the diagnosis. These patients are often mistaken for overactive bladder or recurrent UTI, but you should remember, in a patient with interstitial cystitis or bladder pain syndrome, the urine is always sterile, and overactive bladder patients may have urinary symptoms of urgency of urine and increased frequency of voiding, but presence of pain is completely not an overactive bladder symptom. So moving on to SBAs, a 54-year-old nulliparous lady presents with recurrent dysuria and frequency worsening over past 4 months. She smokes 10 cigarettes per day and repeated midstream urine cultures at her GP have never demonstrated an infection. Her urine analysis demonstrates a 2+ hematuria. You have also sent a repeat MSU for microscopy culture and sensitivity, but what would you do next? Well, as we already saw, in such a patient, we need to have a low suspicion for malignancy. Hence, an ultrasound of kidneys, ureters and bladder would be the appropriate next step to do. This is a cystoscopic image of a 60-year-old lady with recurrent urinary tract infection and hematuria. What does this represent? As you can see, this shows some kind of growth in the bladder, and it is not a typical Hunner's lesion in that there is no radiating blood vessels, there are no areas of scarring and there are no glomerulations. So this is most likely to be a carcinoma of the bladder. A 35-year-old woman complaining of urgency, frequency and lower abdominal pain. Last 5 cultures are negative. She does not respond to antibiotics. What will be your next line of treatment? Well, as we already saw, this abdominal pain urgency frequency is typical of bladder pain syndrome, especially with the mention of sterile urine cultures. Hence, the diagnosis in this patient is bladder pain syndrome, and the next line of treatment in a patient with bladder pain syndrome is going to be, that is the first line is going to be conservative management. That is, you are going to give them analgesia, stress relief, dietary modification, exercise, physical therapy, support groups. So if this treatment fails, we will be referring them to secondary care. So the second line treatment, just for revision, is going to be oral amitriptyline and cimetidine. If that doesn't work, refer them to a multidisciplinary team who will decide on giving intravesical therapies. If that doesn't work, then the next line is going to be peripheral nerve modulation, including posterior tibial nerve stimulation or sacral nerve stimulation and or cyclosporin A. If none of this work, then the fifth line therapy is going to be hydrodistension in cystoscopy, and very rarely these patients may require surgeries, but usually that is done under discussion at a tertiary care center. So before we end, this is keywords in bladder pain syndrome are going to be in a woman with frequency, urgency, pain on bladder filling and cystoscopy showing multiple small hemorrhagic areas. These are known as glomerulations. This presence of petechial hemorrhages always point to interstitial cystitis. Also remember, an overactive bladder patient will not have pain. So, any patient with pain, frequency and urgency, think of bladder pain syndrome, and based on what treatment has already been given to her, move on to the next treatment in the algorithm that we saw earlier. Good luck and thank you.